The clinical scenario is 72-year male patient presenting with chest pain since 4 days. The pain, it is increasing on applying the minimal pressure over the precordium. He came for routine evaluation. His ECG is as follows. What is the diagnosis? The options are the anterior wall MI, inferior wall MI, then benign early repolarization, and then lateral wall MI. So the chest pain is there almost since 4 days. And the pain, it is increasing on application of minimal pressure over the precordium. So you have to understand that if it is secondary to MI, the patient usually will not survive up to 4 days. Okay, that is first point to rule out MI. Second important point is the pain of MI does not increase on applying the pressure over the precordium. That is another point which is against your myocardial infarction. Right now, if you take the ECG changes that you are observing here is more or less the axis, rate, rhythm and everything is fine, but you are noticing or you are observing that there is presence of the ST segment elevation in the precordial leads, that is from V3 to V4. But another important point to rule out MI, see, in patients with myocardial infarction, you will be having the reciprocal changes, right? So what will be that reciprocal changes? The reciprocal changes will be ST segment depression will be there. But if you take this particular ECG here, there is no reciprocal changes, right? There is no reciprocal changes. So there is no reciprocal changes. You are having the ST segment elevation in the precordial leads. This is suggestive of the benign early repolarization. Now, let me tell you about the benign early repolarization. Benign early repolarization, remember, this is one of a normal variant. Right, this is one of the normal variant. So this benign early repolarization will produce widespread ST segment elevation. Right, this will produce widespread ST segment elevation, particularly in the precordial leads. Right, or it can be present even in all the leads that mimics your pericarditis, and up to 10 to 15% of the patients presenting to the emergency department with chest pain, they have this benign early repolarization. Okay, 10 to 15% of patients presenting to the emergency department. Now, how will you rule out this from MI? One, in case of benign early repolarization, there is no reciprocal changes. That is one point which is against MI. And second important thing is, even as the time progresses, there is no dynamic changes within the ECG. In MI, there are some dynamic changes in the ECG. I'll tell you what are those. But here, there is no dynamic changes within the ECG as the time progresses in case of benign early repolarization. Okay, right? And what exactly is the physiological basis is poorly understood. But you have to remember, it is a normal variant. It is not any indication of underlying cardiac disease. Okay, and what is the age group at which you see this commonly is usually around the slightly on the higher age, around 50 to 70 years, you can have this benign early repolarization, and that too it's a rare phenomenon, but usually it occurs around the age group of 50 to 70 years. And how to recognize the benign early repolarization? Okay, so how to recognize the benign early repolarization is, number one, you will have the presence of the ST segment elevation, and that particular ST segment elevation, it is prominent in the precordial leads. Right, it is prominent in the precordial leads. And what are these precordial leads? That will be V2 to V5. In these particular leads, the ST segment elevation, it will be prominent. And that morphology of the ST segment elevation, if you see here, there will be slurring or there will be elevation at the J point. Right, there will be slurring or the elevation at the J point. And how will be your T wave? The T wave, it will be asymmetrical T wave. Right, the T wave, it will not be symmetrical T wave, it is asymmetrical T wave that will be there. And this particular asymmetrical T wave, it will be concordance with the QRS complex. right? It will be concordance with the QRS complex. Okay, that is about how you will identify the benign early repolarization. And as I have said you previously, there is no reciprocal changes and there will be no dynamic changes within the ECG, right? There is no dynamic changes within the ECG. And what will be the degree of ST segment elevation? So in the precordial leads, right, in the precordial leads, the degree of ST segment elevation will be less than 2 mm, whereas in the limb leads, the degree of the ST segment elevation will be less than 0.5 mm, right? It will be less than 0.5 mm, okay, in the limb leads. And you have to remember the ST changes, whatever they have developed, they are like stable over time, right? They are stable over time. There are no dynamic changes. So these are the ECG changes to identify the benign early repolarization. So number one, you will have the ST segment elevation exactly at the J point, and how much that will be. In the precordial leads it is less than 2 mm, and in the limb leads it is less than 0.5 mm. No reciprocal changes and stable changes, and that T wave will be a symmetrical T wave, and that will be concordant with the QRS complex. Okay.